Good afternoon and welcome to our ANA Live. We are very happy to welcome Dr. Anthony D'Ambrosio, who is going to talk to us about Gamma Knife and its use in treating acoustic neuroma. We're excited to be here this afternoon and really excited to welcome you. Dr. D'Ambrosio, if you want to go ahead and introduce yourself and tell us a little bit about the Gamma Knife Center, that would be great.
Great. Well, Melissa, thank you for the opportunity, and thank you to everybody who's tuning in today. I hope this is an informal conversation that adds value to you and the people that you love that are dealing with acoustic neuromas. So we'll keep it informal. I know there's a question and answer session at the end, and I can't wait to hear your thoughts. So I'm going to share my screen here just to get started. And I got a brief slide presentation to kind of get everybody on the same page and maybe stimulate some thoughts. So first, thank you very much to the ANA and to Melissa for reaching out and for setting this up. I will be focusing on Gamma Knife Radiosurgery for acoustic neuroma treatment. That's a picture of me pre-COVID. COVID took the beard away so I could wear a mask, which hopefully all of you are doing as well. So my name is Anthony D'Ambrosio. You always want to know why you're listening to someone. I feel that I put a lot of time and energy into trying to do as best as I can to be a good doctor and a good surgeon. Some of my training has been through the South at Chapel Hill and then Vanderbilt for medical school. And then I came up to the Northeast where I'm from for neurosurgery residency and then went down to Florida for a skull-based fellowship. Currently, I've been working out of New Jersey for the past 13 years at the Valley Hospital. I direct the open neurosurgery program, and I also co-direct our Gamma Knife Center. And I run, with a bunch of my colleagues, I run our neurosurgery practice in New Jersey. I live in northern New Jersey, and I'm proud to say that I'm a husband, father of 2 daughters, and companion to my dog. So that's me. Quick plug about where I do my Gamma Knife all the time is at the Valley Hospital in New Jersey. These are a few of the docs that I work with. We opened our center in 2011, so we've been running for quite some time, and we have a wonderful team there, and I thank them for giving me the opportunity to treat our patients and speak today. So briefly, just to get everybody on the same page, so we're all using the same terms, and you know, when you hear different terms thrown around, we all sort of know what we're talking about. So the acoustic neuroma is also known as a vestibular schwannoma. So a lot of people will use these terms interchangeably. And it's important sort of to know if you're dealing with a vestibular schwannoma or an acoustic neuroma, like what exactly is it? Years ago, there was a pathologist whose name was Schwann. And he named a cell called the Schwann cell, and it's this pink cell that you see. It sort of wraps part of the neuron called the axon. And when these Schwann cells reproduce themselves, they create a schwannoma. So when you talk about a vestibular schwannoma or an acoustic neuroma, that's what you're talking about. And they're almost always very slow-growing, benign tumors. They grow maybe 1 millimeter or 2 a year if they grow at all. They're almost always located in the cerebellopontine angle or in the internal auditory canal. So there's a little picture here, more of a cartoon sketch diagram that shows where your ear is. It also can show you where the brain is, and I'll use a little highlighter here. So this is your ear, this is your brain, and then between the brain and the inner ear cavity, there's 4 nerves that run back and forth between the brain and the inner ear. One is the nerve that moves your face, called the facial nerve. One is the nerve that you hear with, it's called the cochlear nerve. And then the vestibular schwannoma will grow off of one of the 2 vestibular nerves. So there's 4 nerves, 2 for balance, 1 for hearing, and 1 that moves your face, that are all sort of involved when we think about acoustic neuromas. These usually present because of symptoms. The hearing nerve, called the cochlear nerve, is the weakest nerve. It's almost always the first problem is some sort of hearing problem. So a lot of times patients will initially present with a hearing problem, usually to a hearing specialist or a neurologist. Other times the other nerves can be involved as well, but a little less common. For balance problems would be the vestibular nerve, or for some facial problems, that would be the facial nerve. And then detection to figure out that you actually have this, usually, most commonly, it's a hearing test that shows one side is weaker than the other, and that often leads to an MRI. This is a picture of an MRI. This is a picture of a kind of medium-sized vestibular schwannoma on the left. Radiographically, everything's reversed, and this big orange arrow comes with the scan and tells you where it is. So that's sort of the background. I think everybody's probably heard of most of this stuff before, but it's important to kind of start out and just let everybody know where we are in the head and what we're talking about. So then once you're in the category of people that have an acoustic neuroma, the key thing is to figure out, how should I be dealing with this? And many of you may be in the part of your journey now where you're trying to figure out, what do I do with my acoustic neuroma? And other people may have questions about, I had mine treated, was it the right move? What do I do next if it comes back? So as a physician, I always look at several key variables to try to figure out, how do I manage this? One key variable is going to be the size. Another key variable is going to be the symptoms. What exactly is going on that brought this to your attention? And then another key thing is obviously you, the patient, or your loved one. There's a lot of variables involved with trying to manage these things, and you have to take them all into consideration when you're thinking about what you ought to do, and is it the right move for you. When you move on to management, there's management by not doing anything at all, called observation. So you're not doing anything invasive, but you're taking some tests, or you're watchfully waiting. And then there's treatment options. When should I treat? Why should I treat it? How should I treat it? And we'll get in specifically to some of those, and more specifically into gamma knife. So when you look at key variables, when you Google things, you can Google acoustic neuroma and you can Google vestibular schwannoma, but it's very hard to get into the details that might be specific to you or your loved one in terms of size or symptoms. So if you were to say, okay, let's look at size differences, what you can see here on this scan is these are two different scans, but they're both called acoustic neuromas or vestibular schwannomas. And on this scan, you've got a small lesion, this little white thing here, that's not causing a lot of pressure on the brainstem, but might be causing hearing symptoms or balance problems. And then on this one, you have a very different vestibular schwannoma that is very large and that is compressing the brainstem and the cerebellum, and probably presented very differently. Both of them called the same thing, but clearly very variable in their size. And then when you get into symptoms, most people present with some hearing nerve problem, either muffled sound or even a ringing or a humming in their ear. Secondary to that, people can present with some form of intermittent or constant balance problems. Very rarely do we see the facial nerve irritated. Sometimes we see the nerve next to it, called the trigeminal nerve, that can give you some numbness in your face. It's not usually directly related, but it can be indirectly related. And sometimes we see people come in clumsy because their brainstem is compressed, or they have what's called hydrocephalus. So very variable, but all these variables make a difference when you think about what should I have done. And then obviously the patient. Some people come in their 80s, other people come in their teens, and some people come in with other medical problems or on blood thinners. So all of these things come into consideration, and you have to be very specific with all of them before you make a recommendation or choose a treatment. So when we get into management options, one of the things you have to think about is, should I just observe this? Maybe you had a migraine, or maybe it was found for other reasons, and now you find a small vestibular schwannoma or acoustic neuroma, but everything else is fine. So oftentimes what we'll do in those situations is observe. You might get MRI scans on a regular basis. You might get hearing tests on a regular basis, and just watchfully wait. And sometimes that's appropriate, and sometimes it's really not. Physical examinations, watching for symptom progression sometimes could be enough. Other times, and more traditionally, you'll have a lesion that's maybe pushing on some structures or taking up a lot of space, like that second MRI scan that I showed you. And that's when we think about the more traditional surgery, where maybe we're going into the hospital and there's an ENT surgeon combined with a skull-based neurosurgeon, and we're talking about larger incisions and all these other things. That's your traditional surgery option, of which there's some nuances to surgery that would be a whole nother Facebook Live discussion, but it's certainly something that many of you probably come across. And then there's the bucket called stereotactic radiosurgery. So stereotactic radiosurgery is a form of radiation that's done in, usually one session, and it's very very precise radiation. And under that umbrella of stereotactic radiosurgery is where gamma knife sits, cyber knife, proton beam, all these different names for different ways to deliver that. And it can get kind of confusing. So when we get into the world of not traditional surgery on the one hand and not observation on the other, but we're talking about this kind of in between minimally invasive thing called stereotactic radiosurgery. What does that mean? It's a big set of words, a big term, not all that common. So the way that I try to tell my patients to think about it is stereotactic radiosurgery is a generic name for a technique, kind of like photocopy. And within that, there are trade names or brand names for different machines that provide radiosurgery or stereotactic radiosurgery. There's a CyberKnife machine, there's a Gamma Knife machine, there's a BrainLab machine. And it's kind of like there's an HP photocopier, there's a Xerox photocopier, there's a Canon photocopier. They might all produce copies and scans a little bit differently. You might like one better than the other. They might serve your purposes better, but they're all photocopiers. So that's the way to think about SRS or stereotactic radiosurgery. And then when you break down the term stereotactic radiosurgery, what does each term really mean? So all that stereotactic means is that your team has to put your vestibular schwannoma in a three-dimensional box somehow in order to get the radiation there. So stereotactic is just that high school math where you got your X, Y, and Z coordinates. You create this 3D box, and the computers nowadays can get a target within that 3D box. And that's a stereotactic coordinate system. So stereotactic just means X, Y, Z. We find some coordinates and we can circle little things in that box and treat them. Radiosurgery can be broken down into radio, just means radiation, and surgery. Now, this is where it gets a little tricky. It's radiosurgery. They use the word surgery to try to make you think of one session and very sharp and very accurate. So most people, when they think about radiation, they think about maybe things spreading or other things getting hurt, but radiosurgery is very tight. It's very precise. And one of the analogies that I use with my patients is if you took a fine paintbrush to paint a small circle, you could do it very accurately with a fine paintbrush. But if you used a spray paint can, you'd get a lot of spray. So radiosurgery is like the fine paintbrush where you don't spill any paint, you don't spray any paint. Sometimes radiation therapy or fractionated radiation therapy, which has been around a long time and is used for other diseases where it's cancerous and you need 30 doses, you might get a little bit of a margin or a little bit more of a spray with that than you do with radiosurgery. So that's just the terminology for these things. The platform that I like and the platform that I use as a neurosurgeon is called Gamma Knife Radiosurgery, and this is one of those trade names, and I'll just get into this briefly. So Gamma Knife Radiosurgery, we abbreviate with GKRS, Gamma Knife Radiosurgery. And it's a very nice, accurate platform that can use either a head frame to keep people's heads nice and steady and keep things accurate, or it can use a mask. So this is just some pictures from our clinic of the Gamma Knife head frame here. It's a 4-post system with a ring on the bottom. This is what it looks like when it fits on a patient's head. It's a little bit strange. It's probably the most anxiety producing aspect of Gamma Knife is the fact that you have to put a frame on. It only goes through the skin. It just touches the skull. We numb people up. People in their 90s blow through it just fine. People who are young do just fine. Most of the anxiety is thinking about it, but it actually is, it's been around a very long time and it makes the machine extraordinarily accurate. So frame-based is great. The company has come up with a mask-based system now to try to kind of keep up with competitors who have masks. It's also very accurate and can be used in certain settings as well. And that's called the Icon mask. And that's shown down here. It's a mask system that's molded to people's faces. And then using an optical camera and a little thing on the nose, we control for motion. So both are available. And then when you think about, well, what the heck are you guys actually doing when you do this if you're not doing surgery? What we do with Gamma Knife is we get an MRI scan or a CAT scan in that ridiculous looking frame. And then we send those images to a workstation. This is a screenshot of that workstation where you'll see here's a vestibular schwannoma, acoustic neuroma in 3 different planes. It's the white spot. And then we put doses in here that are extremely tight. And we're able to plan a dose of radiation that pretty much only hits that tumor and nothing else. but is enough to kill that tumor in usually one treatment day, one session, and it's usually a half a day. Depending on the size and the dose, most people are pretty much done before lunch, so it's quick. And this is kind of a technical diagram to just show the knife-like precision of radiosurgery. We like to say knifeless because we think knife confuses people, but what you're just seeing here is that basically, if we want to prescribe a certain dose of radiation to the tumor, everything around it doesn't see much. So the dose here, you see like a waterfall just dropping off precipitously. It doesn't drag out like these curves. There's a very steep drop off. So there's not a lot of injury or excess dose of radiation. That structures really close to the tumor don't see much radiation. That's what makes it so safe and so effective. Now, gamma knife radiosurgery has pros and cons, and it also has a lot of different risks and benefits compared to observation and compared to traditional surgery. So in this column here, I've just said, look, these are the things I think most patients or loved ones need to take home with them today. Gamma knife radiosurgery for an acoustic neuroma is a same-day procedure. It is not done in an operating room. It's usually done in a gamma knife suite, and people usually leave before lunchtime. So it's same day. In my practice, it's almost always one day, one fraction. It's really a half a day. There's no real bleeding risk, which is nice. So it's sort of bloodless, except for these little injections that can have a little red drop of blood. There's really no bleeding risk as opposed to a traditional operation. There's no need for a ventilator or breathing for people. The way that we do it, we give some numbing medicine, a little oral, like a pill for Valium or an Ativan, and people will get through the frame and the MRI just fine. So there's no risk of creating a pneumonia or needing a ventilator for anybody. And then the other thing that's really nice about gamma knife is the facial nerve that controls your smile and your ability to close your eyes. Almost, you can never say 100%, but there's almost a near 100% facial nerve preservation rate when gamma knife's done correctly. It's not, I'm sure there's been problems with in some practices, knock on wood, I haven't seen it yet, but for the most part, it's the safest thing when you're thinking about facial nerve preservation and a treatment. Now the negatives over here, I think one of the negatives, people like to think that gamma knife's a laser that's going to evaporate or eliminate the tumor. It does not. Gamma knife is meant to control medium to small size vestibular schwannomas or acoustic neuromas and just kill them in their place. Sometimes a small percentage of them will retract a little bit. You can see some shrinkage, but they usually don't disappear or vanish. So that's a negative if your particular acoustic neuroma actually is pushing on something, and that pushing is causing you problems like facial numbness or balance problems or hydrocephalus. If the tumor is actually big enough that it's causing compression of something, gamma knife usually isn't the first option. It could be a backup option. Usually traditional surgery is the only thing that we really can rely on to reduce the overall size of the mass. So that's sort of a disadvantage of radiosurgery. Hearing, the hearing that causes problems with these vestibular schwannomas are really quality of life problems for a lot of people. Either they're causing a ringing or a tinnitus that the patients just can't get away from, or patients want their hearing back. The hearing nerve itself is very fragile. It's actually like an extension of brain tissue. So it's very sensitive, very hard for any treatment or observation to preserve. So holding on to hearing or fixing tinnitus oftentimes is very difficult. That said, if you need treatment and you don't need traditional surgery and your hearing is okay, it's just slightly weak, in my practice, gamma knife affords the best chance of holding on to what you have, meaning if your hearing is still quite good at the time of gamma knife, we stand our best chance of preserving it. With no guarantees, it is certainly the most frustrating aspect of the human body, is that we can't guarantee hearing preservation with anything that we do. The head frame can cause some forehead swelling that's temporary, or it can cause some swelling within the treatment zone itself. So that's one of the downsides of any radiation treatment, gamma knife included. And there is a recurrence rate that can happen with anything we do, but particularly with gamma knife or any other sort of radiosurgery, you can have the tumor grow through it. There is a chance over time that the tumor years later could start to regrow again. So that's one of the potential downsides or complications of gamma knife. So then when I think about radiosurgical platforms and you try to say, the most common question that I get is, what's better, Gamma Knife or CyberKnife, right? They're both outstanding technologies, very good platforms. The way that I think about Gamma Knife, and the reason why I lobbied Valley Hospital, my hospital, to put a Gamma Knife in so that neurosurgically we could do the open things, and then if I needed radiation surgery, I really wanted a Gamma Knife, is because Gamma Knife's actually been around the longest of all these dedicated brain platforms. It was created in 1968, so we have a lot of data. I can share a lot of information from across the globe of Gamma Knife centers, because the Lexell and Excel, the company Lars Lexell, they've been collecting data on their patients since 1960s, 1970s. So we have a lot of data to say how safe Gamma Knife might be. We have a lot of data to say what the side effects might be, what our control rates might be for things. So I like that aspect. I can share some information with patients that's robust. Gamma Knife doesn't have a lot of moving, rotating parts. I like that. It just means there's fewer things to break down. And the really nice thing for a doctor is that Gamma Knife really only can do procedures from the top of the neck up. It really can't drop below that. So it's really, really good at brain stuff, but it can't be converted to treat a prostate or a breast or a lung. So the analogy that I use is my Hugh Jackman analogy. So I love Hugh Jackman. I think he's great, right? He's a really good dancer. He's a really good singer. He's a really good actor. But if you go into each one of those things, there's probably somebody better at each one of those specific things that, Hugh Jackman's not the best of the best. So for me, Gamma Knife, because it's dedicated to the brain, it's extraordinarily good at brain things, but it can't do anything else that well. Whereas any machine that can be converted to treat another organ system, although versatile, probably isn't the best in class, although very, very good. And most importantly, I know that Gamma Knife works. In my experience, it's got some very, very good outcomes. So that's how I think about sort of the Gamma Knife versus something else platform. And that's just my opinion. It's very hard to prove. When you talk about outcomes for vestibular schwannomas and acoustic neuromas, the growth control rate, meaning is this going to continue to grow on me after Gamma Knife, is very, very good. Greater than 90% chance that we can stop growth for lesions that are medium to small. So 2.2 centimeters or less is a very good growth control rate. I mentioned earlier your facial nerve, your ability to smile and close your eye with Gamma Knife, the preservation of that nerve is extremely good. There's really not a risk to other functions in your body, right? Because the Gamma Knife is so focused, damaging something else or causing some memory problems or other things like that are very, very rare. And then hearing, obviously, hearing preservation has a lot to do with how a patient comes in. If they come in with not so good hearing, it's very hard to save hearing. If a patient comes in with very good hearing, it's a little bit easier to save hearing. So hearing remains one of those tricky things for us. Gamma Knife can fail, and if Gamma Knife fails, there is good evidence that you can retreat with Gamma Knife. We do worry about hearing with a second Gamma Knife treatment, and you obviously can operate. There's debate in the field as to whether or not Gamma Knife makes future surgery, should it be necessary, harder because it's stickier. I personally have not seen that, but I know some very good surgeons who say that once you radiate something, it becomes harder if it needs surgery. I have not personally seen that happen, but I'm sure there's some very good surgeons who have. So that's sort of a debate that the jury's out on. But surgery can certainly be done after Gamma Knife. So that's really the long and short of the formal presentation for me. I would say some of the take homes that I would like everybody to think about here is that radiosurgery, and particularly Gamma Knife radiosurgery, for me is very safe. We have good safety numbers. We have good effectiveness numbers. It can be used as an upfront treatment. It can also be used if someone has surgery for a large tumor, but then the surgeon had to leave a smaller piece behind and you need to Gamma Knife that small piece at some point in the future. It's excellent for that as well. I want you to know that Gamma Knife's not new, even though you might not have heard of it before. It's actually been around a very long time. The computers around it are new, and it moves faster than it used to, but at the end of the day, the treatment's the same as it was in the 70s, so the data is very good. It's not a new experimental platform. When you're looking, if you're on that, I know I have a vestibular schwannoma, it's growing on me, I don't know how to treat it. when you go look for experts, it's really important. And this applies to almost anything in any healthcare field. You want to find a doctor or a team that can provide you with, both Gamma Knife or surgery. They have good surgical experience and they have good radiosurgical experience, because when you find that team really isn't biased one way or the other. And you want to be careful about bias. You want to be careful about incentives. If all someone does is one thing, they're probably going to be, whether they know it or not, that provider or that team is probably going to be a little biased towards that thing. Whereas if they can do both, and they can do both equally well, you're probably in the best hands to make the best decision for you clinically. So try to find experts that have access and experience with both. And then the one question I get all the time is, you do a lot of these, right? How many of these do you do? And I always try to encourage patients to not just stop there, but say, how many of these do you do well? Because if you do a lot of them, you want to know that you're doing them because you should as a team, and you're getting good outcomes. So, don't be afraid to ask when, if you're in that part of your journey or you're searching for teams for a friend or a loved one, be certain not just to ask, do you do a lot of these a year? Because that could be good, that could be bad. You want to do the right amount per year, and you want to have good outcomes. So, there's data out there to say what good outcomes are. So ask that last extra piece, is how many of these do you do well? And these are some of the patients we've had at Valley, happy Gamma Knife patients. The one gentleman with his headphones on is a DJ, and to date, we've been able to save his hearing, which obviously has been wonderful for him. And hopefully you're going to be in the happy patient category if you're not already. I'm sure with the guidance of the ANA and Melissa, you've got really good resources. You've got a good network of people, and I wish you all the best. This is a shameless plug for our center. We're located in northern New Jersey. It's the Valley Hospital, the Valley Gamma Knife Center. We think we have a really nice shop there. It's a pleasant place to be if you're in the area or have loved ones in the area who need us. So that's our information there. And I guess, Melissa, we can open up the floor to questions. I will stop sharing to figure out how to do
Awesome.
that.
Great. Thank you so much, Dr. D'Ambrosio. That was really,
Sure.
really helpful. And we really do appreciate your time and your time in answering some questions. We have several. I'm Melissa Bombick, by the way. I'd never introduced myself. I get nervous when these start. And so I forgot to introduce myself. I'm with the Acoustic Neuroma Association. And so, yeah, I've been monitoring questions as Dr. D'Ambrosio has been talking. And one that we've gotten several times is follow-up MRIs. After you receive Gamma Knife or CyberKnife, any sort of radiation treatment, how long should you be going and getting follow-up MRIs? And, we've had this question, like I said, multiple times, and it's been people who are a year out, people who are 5 years out, 10 years out, even 15 years out. Should they, how consistently should they be doing that at those different timeframes?
Great question. Again, most of the questions I can give you very good generic answers. I can give you my formula for. Just understand a lot of these vary depending on your own situation. So you would always want to ask your team why they're getting scans or why they're not getting scans. But in general, I would say if you're an upfront treatment with Gamma Knife, I get scans every year for the first 3 years post Gamma Knife. So if you're treated today, I don't scan you until 1 year from today. And then I do that 3 times. And I also will get hearing examinations every year, but I'll stagger them. So I'll do the hearing test 6 months from now, and then every year thereafter. So every 6 months, you're getting an objective assessment of what's going on. That can change. I used to get, when I first started, I got scanned 6 months after Gamma Knife. And what I found was on the 6-month scan, patients look great, but their tumor always looked a little plump. And it was counterintuitively a good thing, because what was happening is the tumor, as Gamma Knife doesn't work right away. Radiation surgery, CyberKnife doesn't work right away. There's a lot of biological injury that happens to the tumor on purpose that causes inflammation and cell death. So Schwannoma, cell death, which is good. You want it to die. So what happens is it kind of gets a little inflamed, and sometimes people get, if they came in with some balance problems or some other things, they could get a little irritated during that swelling period, and then the swelling period naturally goes away. By 1 year, you know what you're dealing with. So a lot of my patients came in where they had a scan in 2015, and then they had a scan in 2017, and then in 2019, and each one of them showed a little growth. So we had this pre-existing MRI series of growth. So we plotted a line. We're like, okay, you're growing 2 millimeters per year. You're 40 years old. We can't let this grow anymore. So then we treat it in 2019, and then every year thereafter, I just hope that that growth curve flattens. And then when I get to year 3, if the hearing's preserved and the growth is flattened, then I expand to a 2-year scan, and then sometimes a 3-year scan after that.
Okay. And can you talk about how that swelling, how do you see the difference between the swelling and the growth? Because does the swelling extend past that 1-year mark sometimes?
It usually does not. It's a great question. So if you're starting to see, this continued growth, usually at year 1, it should be flat. If it's bigger at year 1, I worry it didn't work. So at 6 months, it was bigger, and I'd be like, ooh, is it growing? And then I'd image it at 12 months, and it'd go back down. So usually by 12 to 24 months, you really should see a response that's flat. So you should not, again, this is all caveat, but more often than not, you do not see continued volume growth beyond a year if it's working.
Okay.
And again, that's a very general statement.
Sure, that makes sense. And with that, then, how about symptoms? Like, when would you start to start seeing symptoms appear that may or may not be permanent? Maybe they would be due to swelling. If you started to have, something, maybe some facial weakness or dizziness or something happening.
Yeah,
could that
a great question.
Start right after, or when would that start?
Usually not right after. So if you come in dizzy, the gamma knife can stir up some dizziness. So if you're presenting symptoms or vertigo or dizziness, they almost always, that means your vestibular apparatus is very sensitive, and we're going to stir up some more inflammation. So I usually send people home with a Medrol dose pack or some form of steroids, and a caution to say, counterintuitively, that you're feeling worse, but it's a good thing, because it's not it's miserable for you, but it's good in that the tumor's dying, and we got to ride this out. So you can see post-operative symptoms getting worse, especially if you came in with symptoms. You can see those get inflamed anytime within the first year. Everybody's immune response and reaction to injury is a little different. Some people can get very dizzy within the first few weeks, other people 3 to 6 months. Usually by 3 to 6 months, things are tapering off for the most part. But I have had 1 or 2 patients where we put them on a steroid, they got a lot better, we took them off the steroid, they were okay for a month or 2. And then a month or 2 later, they got inflamed again. We put them on a little steroid. Those people we tend to take a few more pictures of just to make sure there's nothing weird going on. But for the most part, it's just a reaction to cell death. And depending on how inflamed the nerves were before we started, often dictates how quickly and how sick some people might get. It's extremely rare. I would say it's extremely rare to get violently sick or have a bad reaction to gamma knife unless you're coming in a little bit off.
Sure.
So for the most part, you don't see that very often, but it can happen at any point in the first year for the most part.
Absolutely. Okay. What about, we had several questions both before the this event started and then during as well, about balance and sort of surgery versus radiation and balance. With surgery, if the balance nerve is cut, then the other side tends to, kind of compensate. But with radiation, obviously that's not happening. So long term, what is your experience with patients who come in with balance issues? And then what are their results like afterward?
Yeah, so it's a great question. Balance is tough. If you come in with balance problems, you're right. It usually means that the nerve that has the tumor on it has caused that particular nerve to send bad messages to the brain, which makes it very hard to accommodate. Usually if the lesion is small, we see that more often than if the lesion is big. So if the lesion is real big, usually the nerve that it's growing off of isn't sending signals anymore, because the tumor completely cut off the nerve on its own slowly over time. So this is all anecdotal, but for the most part, if the lesion's a little bit larger, we don't see those balance problems. The small ones can cause some wicked dizziness. So we try the gamma knife first. We see how you do. I do a lot of vestibular therapy with patients. I try to get them to naturally fix themselves and see if they can accommodate. Everybody that I've tried that on has been relatively okay by 6 to 12 months. They've kind of gotten through it, but there is definitely a school of of thought out there that you just got to cut the nerve. If you're really dizzy, you got to go in and cut it. You might get dizzier after that for a few months, but then you'll accommodate. So I would say in general, I've had relatively good success with a small population of patients with riding it out and physical therapy, as opposed to saying, even for a small lesion, something really tiny that'd be perfect for Gamma Knife, let's not do Gamma Knife, let's go in and cut the nerve. I haven't personally done that. There may be other surgeons that have, though.
Okay. And you talked about the facial nerve, and you talked about, like a near 100%, not total, but that it's a very good option. There was a question that just came in that was, have you seen a tumor that is not suitable for Gamma Knife or radiation, any kind of stereotactic radiation, because of where the tumor is located in relation to the facial nerve? And then I also wanted to ask about, several patients talked about twitching, particularly in their eyes, following radiation. And what is your experience with that?
So I'll answer the second one first. I've seen maybe one or two patients twitch a little bit after Gamma Knife, but not very often. Hundreds of cases. I really haven't seen anyone develop hemifacial spasm or any sort of fasciculations. I personally have not. I'm sure it exists. I just haven't seen that much of it. Sometimes what you could hypothesize is that maybe that's a facial nerve schwannoma. So there are facial nerve schwannomas too. And if your first treatment wasn't surgery and there wasn't a surgeon who went in and actually could inspect and test which nerve it was growing off of, there are some schwannomas that grow off the facial nerve. When we see that, I've seen patients come in with some weakness and some spasms, and you radiate them just the same, but their facial nerve symptoms are significant. There are definitely tumors that, because of the relationship to the nerves and the relationship to the brainstem, surgery is better. Oftentimes you'll go in and it's more the trigeminal nerve. In my practice, if there's compression of the nerve that feels your face, you really got to go in and roll that tumor off of the nerve that feels your face, or else your face is going to either continue to have sensory symptoms like pain or numbness. It's never going to get better. Sometimes it does, sometimes it doesn't, but I don't know of a study that before surgery can tell you exactly where the facial nerve is in relation to the tumor, unless it's really tiny. If the tumor is really tiny, you can see the facial nerve on the Fiesta MRI scan, which is this really high def scan. But if the tumors are bigger and they're crowding things in that bony canal, you just can't tell where the facial nerve is. And at surgery, you can figure it out, but before surgery, it's really hard to know. So most of the surgical decisions are made based on the trigeminal nerve, the brainstem, the size, things like that.
Okay. And we've had several questions. I know that you talked about it a little bit, but several questions wanting to really compare CyberKnife with Gamma Knife. And I know you talked a little bit more about that even during your talk, but can you go through that again? Because we're getting that multiple times.
So CyberKnife does a lot. So the CyberKnife is great for a lot of things, I think. And in medicine, especially in neurosurgery, it's very hard to prove one's better. Unless one's super, super good and the other's super bad, it's very, very hard to show that there's any real difference. And not a lot of people have experience on both platforms. So it's also very hard to get an truly objective opinion. Everybody's sort of got their favorites. I would say intuitively, they're both excellent for cancer, in my opinion. They're both great for brain metastases. I think CyberKnife's a wonderful platform. I don't have a lot of experience. I have no experience on a CyberKnife machine, but it's a linear accelerator. So intuitively, the way I think of it is I'd say, okay, CyberKnife's very good, hasn't been around quite as long as Gamma Knife, and can be converted to do other things, which means it's got some moving parts and pieces. There's this big arm that rotates around. There's shielding that has to go on inside the machine. Sometimes people use masks instead of skull pins on a CyberKnife more often than a Gamma Knife. So for me, if you introduce any variables, you have to accept a little bit of error. Maybe not enough to make a difference, but as soon as you start moving more things and using a mask, or you could have a millimeter of head shift, I personally, if it were in my brain, I'd be like, well, if I'm treating something small, benign, and really close to important stuff, which acoustic neuromas are, I'd prefer to reduce the variability of the machine that I'm on. I like to know that you've got a vast experience of data to quote me. And I'd like to know that it's pretty much dedicated to brain surgery. So although I can't prove that that's better, and I think you could get both camps to argue they're just as good. I don't think there's any data to say that CyberKnife's better than Gamma Knife or that Gamma Knife's necessarily better than CyberKnife. I think within statistical reasoning, they're close. I would just say intuitively, with anything complicated, the more variables I can reduce and the more dedicated I can be to doing only one thing really well, like the Hugh Jackman, Baryshnikov analogy, I would say, well, you just know intuitively, you would assume this machine's got to be at least as good as a CyberKnife, if not better. I couldn't necessarily argue the opposite.
Okay.
Does that answer the question, or
It
is
does.
that a little?
Yeah,
okay.
no, that it does. I think it's great.
There's not as many Gamma Knives around, so I'll go off on my side note here for 1 second. You won't find as many Gamma Knives around, and here's why. The reason is because the Gamma Knife only does one thing really well. It isn't always utilized as much in a healthcare system. So if you have a machine that can be converted to help more patients,
sure,
you could understand and be like, well, I'd rather use the CyberKnife. If they're equal, I'd rather be able to use this if I only have 1 day of brain stuff and I have prostate cancer, something else I want to treat. If this machine can do both of them well, I'd rather use something that's more versatile. So I think you'll hear more advertising and you'll see more of those machines because they can be used more often by the system for more patients.
Okay, that makes sense. We just had a question about why someone would choose, or what the situation would be for someone to choose fractionated radiosurgery over the stereotactic, just the one shot kind of deal.
Yeah, so if we're staying in the world of what we define as surgery, radiosurgery, you can do up to 5 sessions.
Okay.
Okay. So I think the Gamma Knife, and I don't own Gamma Knife stock. I don't run none of that stuff. But I think what Electa, the company, tried to do, because so many people prefer masks, they just don't like the idea of a head frame, is they generated a mask so you could fractionate on their machine. You could do 3 or 5 sessions and treat an acoustic neuroma. It's a little bit of a newer thing for the Gamma Knife. The Icon machine that just came out now has a mask, and you can do 5. I have a great mentor of mine in New York City, and he's doing them now. He feels that maybe there's a little better hearing preservation, and it's obviously more comfortable for some of his patients. I don't know that the data's there yet to tell us if it works as well or if it doesn't. I think there's a lot of intuitive momentum to say, we could do this in a mask. It'd be easier for you, 5 short sessions instead of 1 frame. I'm waiting for that data myself.
Yeah.
Before I do it. I think there's a lot of good arguments to put patients in a mask and do it. I think if your lesion's tiny and it's really close to the hearing apparatus, the cochlea, and you have good hearing, I don't want you to move at all. I'd rather know that I'm using a machine that's got really good data, and you just can't shift out of that thing unless you really try. Whereas in a mask, we know you can wiggle a little bit. So I think the fractionated mask-based treatments is why people are moving towards fractions, is because it's intuitively nicer to just put a mask on.
Yeah.
People who are claustrophobic don't like the mask, but people who don't like, the idea of getting injections, some of them gravitate towards that.
Gotcha. Can you talk a little bit about size of tumor that is appropriate for radiosurgery? So we've had a couple questions about what defines a small tumor versus a medium tumor versus a large tumor, and then what is the cutoff as far as where radiosurgery can be effective? Yeah,
I think in my training at Columbia, and like I said, my mentor at Columbia did a big study that I wasn't directly involved in, but we took care of some of the patients. Very good analysis where the cutoff for me in my practice is about 2.2 centimeters. Now that's also, there's give and take there. You can do 3 centimeter ones with Gamma Knife, and you can say that there's a 1.5 centimeter one that I wouldn't use Gamma Knife for. But in general, you get a pretty good response, meaning no growth or good growth control, over 90% growth control if you're 2.2 centimeters or less. So that to me defines a rough cutoff. But within that, there are some people where I'd say, well, if you're 2.5 and really too sick to undergo surgery, I would definitely try Gamma Knife. I might fractionate that one. You might start to move into, maybe I'll do that in 3 fractions, get a little more of a dose in there. But if you have even a smaller than 2.2 centimeter mass, it could be smaller, but pressing on your trigeminal nerve and giving you trigeminal neuralgia or numbness. Those I would say, well, I can't necessarily, I got to get the pressure off the trigeminal nerve, and the only way I can do that is with an operation. So although it meets the 2.2 centimeter rough cutoff, it's causing cranial nerve issues because it's sitting on something. And the best way for me to get, that pressure off of the nerve that's symptomatic is to physically go in and move it, because the Gamma knife might not shrink it. So 2.2 centimeters is a short answer, but there's a bunch of caveats around that.
Okay. And we have a lot of questions about delayed treatment because of COVID. And where people had decided that they were going to move forward with radiation or whatever treatment, and then everything's been delayed now and shut down. So how important is it, in your opinion, to go get another MRI to sort of check growth, or what symptoms should people be looking for before they start, really being concerned that they need to move forward and that kind of thing?
Sure. Yeah. So I hope you're all doing well with COVID, and plug to wear a mask. It definitely helps. I would say, look, COVID threw a wrench in the works, especially for people who had progression. Something's moving on you, and it's going to make a difference. Or if you were right on the cusp of being able to use radiosurgery and your tumor is going to grow and you're not going to have access to that treatment anymore, I'd move a little faster.
Mm-hmm.
The one nice thing about a vestibular schwannoma is most of them don't move that fast. So you don't really hurt yourself waiting a year or two, unless your hearing is plummeting, right? So if your hearing is really starting to go, you kind of want to get in front of that if it's still salvageable. So I would say if things are changing on you during COVID, you probably want to talk to your team about, how do I stay on top of this? Right now in New Jersey, our numbers are good, right? They shut us down for a while, rightfully so, because of the masks and the gowns weren't available. But as soon as we could reopen, we started treating again. We started treating those patients where we felt that they were kind of urgent. We didn't want it to grow another 2 to 4 millimeters because we were afraid their hearing might become unsalvageable, or, it'd start to push on a structure that we wouldn't want it to push on. The one nice thing about Gamma Knife is, at least at our facility, it's not in the main hospital. There's no COVID patients anywhere, and you don't need a breathing tube, none of that stuff. So as far as imaging is concerned, again, a lot of it has to do with what was your imaging pattern before. Was it stable? Then you probably don't need to go for an MRI. Was it growing, or was your hearing going down? Then you probably need to get caught up in the safest way possible. But on average, it's not an emergency. You can kind of wait until you feel that it's really safe and your exposure risk is low, because that obviously can be much worse than a millimeter of growth.
Okay. And what about when people start to explore hearing preservation or hearing rehabilitation options like hearing aids and stuff like that? Is there any period of time that they should wait after getting radiation to explore those options?
Yeah, for me, I'd like to know where you're settling out at a year. So usually by a year, we can kind of tell if your hearing's going to become non-serviceable or if it's going to hang on, if the neurons are going to hang on and allow you to amplify that sound. So usually about 12 months after treatment, that inflammation has stopped, the nerves have calmed down. You usually kind of know, and that's true of most nerves. If you've had surgery and your eye is kind of going in one direction and you have double vision, but we think it might correct, usually 12 months, 12 to 18 months is long enough to know, this is my fixed deficit. My hearing is 50% compromised and it's going to stay there. So obviously, if you're going to get an implant put in, or you're going to buy a hearing aid and put that cash out, you kind of want to know that your hearing is salvageable. And usually that's 12 to 18 months in my practice.
Okay. And we've talked about some of the side effects that are common with acoustic neuroma in general, but there are some side effects that I think people have heard of that are associated with radiation when they talk about cancer or whatever, the nausea and the hair loss and that kind of stuff. So is that something that is dealt with this kind of radiation?
Yeah, the nice thing about this radiation given in one fraction to only one spot is there's no hair loss. There's no nausea, vomiting like the cancer treatments, unless you're dizzy and that makes you nauseous, but there shouldn't be any direct reason. Yeah. So it's really focused. The nice thing about this is it's like surgery. You just go to the spot that we're worried about and you don't see a lot of other issues come up. The only secondary issues we see is if we put you on some steroids, and that can cause some problems,
Mhm.
but the actual gamma knife itself or any radiosurgical platform is so focused, unless it's something directly in the field that we're treating, you really don't see a lot of these other secondary problems.
Okay. And some of our patients say that their acoustic neuroma has a cystic component. How does that work with radiation? Do you have any difference in the way that you treat? Is there any better or worse outcomes associated with that?
So cysts usually represent some section of your tumor had died, and then there's a cyst that forms or bled into itself, and it forms a cyst. Cysts are tough to manage with radiosurgery. They also at surgery represent tumors that are harder to resect because that death that happened inside the tumor or the bleeding caused inflammation and then made things stick to the capsule. So surgery on cystic tumors is harder. Cysts can grow faster than a normal tumor, so you can see some growth that's beyond 1 to 2 millimeters. For the most part, we don't usually treat large cysts with any form of radiation. They usually need some sort of drainage or direct surgical intervention if they're symptomatic and if they're growing.
Okay. And we always get the question about, long-term research with gamma knife and cyber knife and radiation in general, and what the chances are of malignancy occurring in the tumor following radiation. But I had a question today that I haven't had. I do want you to answer that question, but then also, if the tumor touches the brainstem, is there a chance of necrosis or paralysis on the brainstem? I haven't heard that one before, but I thought that was an interesting question.
So secondary degeneration into a malignant tumor, they try to look at. Again, going all the way back to proving things, Electa, the companies, tried to pool gamma knife in general to see if their gamma knife causes secondary tumors. The best data they can pool isn't the best data, but they don't see any increased incidence of secondary cancers. Having said that, in my residency, I saw a patient who had an acoustic treated years ago and then came in with something more aggressive. So it probably can happen. It's extraordinarily rare.
Yeah.
As far as necrosing someone's brainstem, that shouldn't happen because the dose is so conformal that if you don't move during the treatment, and the treatment, we do what's called dose tolerance. So we trace out the brainstem, we trace out the cochlea, we trace out optic nerves, and then when we prescribe, before we actually treat anybody, we run a simulation to say how much radiation is the brainstem going to see, how much radiation is the optic nerve going to see, how much radiation is the cochlea going to see. And we know historically what the tolerance is of those structures. So we have to keep our doses below the tolerance so as not to cause a problem with those organisms and with those anatomical regions. So if the brainstem is well drawn out and the tumor is right up against the brainstem, we do sometimes have to pull our treatment dose back a little bit, maybe not get as much in there as we want so that we don't necrose the brainstem. So I'm sure it's happened. I'm sure you've got people in your association where they've had swelling in their brainstem or necrosis in their brainstem or a bunch of inflammation from gamma knife or cyber knife. I'm sure it's happened. It can happen to anybody. Everybody's body's a little bit different. But in general, because that dose there's such a steep drop off between what we're giving the tumor and what anything next to it should get, yes, it can happen, but it probably shouldn't.
Yeah.
And you'd have to review, if there is somebody out there, you'd have to review the dose and the treatment day and figure out, do they have an inflammatory problem going on elsewhere? We did know so one of the things about radiation when someone's on chemotherapy is that this thing called the blood-brain barrier is a little more sensitive when you're on these certain meds. So we never would give radiation if someone was also on chemo. We can do that with gamma knife, but radiation in general, like there's other meds that can affect it. So I'm sure it's happened, but there's probably an explanation for it outside of just, saying that radiation surgery can cause this. There's probably something else going on.
Okay. That kind of leads me into another question that we had from a patient from before your talk started, but they had been given Avastin. Am I saying it right? Avastin?
You are.
To control swelling, I believe. But I understand that is, I think it's a chemotherapy drug. Is that correct?
Correct.
And so is that a common practice to deal with swelling from this kind of radiation?
Yeah, so So yeah, more often than not, the swelling that would require Avastin is in the brain itself. So the cerebrum, the higher up part of the brain. If we treat brain metastases, like a lung cancer that goes to the brain or a breast
Mhm.
cancer that goes to the brain, Gamma Knife is very good at helping us treat those without surgery too. But oftentimes you can get necrosis or cell death in the brain around it, and you get these, up to a year or two later, you can get some bad inflammation in the brain tissue. That's where I've used Avastin. When you can go on steroids for a little while, and what's called radiation necrosis or post-treatment inflammation, same thing. The brain is having a reaction in a very delayed fashion to the radiation that it saw. So the tumor's dead, but now the brain around where the tumor was is starting to get irritated. Avastin it's designed to choke off little blood vessels that tumors make to feed themselves.
Mhm.
So the theory was that Avastin could go in and kind of block this thing called angiogenesis, which is to make new blood vessels. It's a good theory. So it's been tested, especially in brain cancer. What we've found, at least for malignant brain tumors, is that the Avastin makes the scans look different by bringing a lot of inflammation down, but it wasn't necessarily, in some cases, curing or making the life expectancy better for people. But they found that it really carved down in any sort of radiation inflammation. So yeah, using Avastin for patients who have a lot of inflammation after a form of radiation treatment is working out. I don't know if there's any really good studies to prove when we shouldn't use it, but in these off cases where steroids just too much, we don't want to leave someone on Decadron for months.
Yep.
Avastin's nice because it doesn't have a lot of the side effects of Decadron or steroids, but it also brings inflammation down quite quickly in the brain. There's some downsides to it that we can or can't get into, whatever you want to do, but a lot of times you can't have surgery when you've had Avastin recently, so there's some other things to consider, but it isn't out of left field to try Avastin for refractory inflammation that doesn't respond to other things.
Okay. We're getting down to the end of our time, but I wanted to see if you could, I can't remember if you talked about this in your presentation, if you could talk a little bit about how long the entire procedure takes, and if there's anything that people should do to prepare for it, to get ready to come in. Is there anything that helps them, on the front end?
Sure. So Gamma Knife, usually there's a couple consultations that happen ahead of time, usually a tour of the facility pre-COVID. We're even getting, but basically the way that we run it at Valley Hospital is patients come into their own nice little room with a TV and a radio around 6 in the morning. There's really no need to stop medications or pack a bag, right? So you have a family member come with you, check in, you sit down in a nice room, and we give you some medicine, a pill usually, just to calm you down, and we put some cream on your scalp to start numbing it. Then by 6:30 in the morning, I'm usually placing that head frame. It takes about 10 minutes, 15 minutes to put that frame on. Then patients are sent in within our building to an MRI scanner across the hall. We get the necessary pictures in the frame, and then by 8:30, the pictures are up on our planning station, and we're planning our target dose. And say usually by 9, you're moving into the actual Gamma Knife machine. You lay on a nice couch. The head frame holds your head in plate. We do a few timeouts. We all leave the room. We can talk to you, see you. You can speak to us. And then the machine does its thing. We hit a button. The machine moves your head into the right position, prescribes the right doses to your tumor. And down to the 10th of a minute, we know exactly how long the Gamma Knife's going to give you the radiation. It's usually less than an hour. Okay. So then maybe by 10 o'clock, you're off the machine. You go back into your own private room. The head frame's removed, maybe a couple little Band-Aids here. And then a family member usually takes you home within 45 minutes. So if you're the first patient of the day, that's usually how it runs. So on average in our center, you're leaving by 10:30 or 11:30, and you're going home. Couple restrictions, which is basically don't go crazy that first day. You don't drive yourself home because we gave you some Ativan or some Valium, but there's no IVs. There's really not a lot of downtime. The next day you can go do whatever you want to do. The only thing I tell people is not to schedule Gamma Knife right before wedding photos or something else, because sometimes your forehead gets a little puffy and you don't want to plan pictures right after that. But other than that, people can go back to work. There's no lifting restrictions. There's no driving restrictions.
Great. Well, thank you so much for your time today. Thank you for taking the time to answer all these
Thank you.
questions. And we really, really appreciate it. I want to tell everyone that's watching, I want to thank you for taking the time to join us today, and let you know that our website is www.anausa.org. You can check that out. We're having, because of COVID, most of our support group meetings have moved to a virtual format. So we have support group meetings happening, and they are happening all over the country. However, location isn't quite as important right now. So anybody is welcome to attend. You do have to register, but you're welcome to attend any of those. So some of them are just caring and sharing what we typically do, and then others have presentations. So check out our website and look for those. And then also follow us there and on our social media for more presentations like this. We are working to set up more Facebook Lives and webinars for the fall. So we'll be having those coming up. And again, I want to thank you all for attending, and Dr. D'Ambrosio, thank you so much for taking.
Yeah, no, thank you. Be safe, everybody.
Have a great afternoon.
Okay, thank you.